in a chat, or we can just unmute and ask, sorry, and speak. All right, thanks, Vivian and Darius for that. So when you want us to have discussion, I know you've had a long day of lectures. I don't know if I'll try put my video on. It will not be very clear. I'll just try. If it's affecting our call, then I'll change that. So anyone who wants to give it a try? Okay. Medicine from S-born medicine is no longer straightforward cut-off path for all. Interesting. Does it mean it is for some? That's good. Anyone else? What comes to your mind when you first saw this topic of discussion? What came to your mind? I'll appreciate comments and okay. So that's Kirwa. Joy is saying other possibilities apart from the traditional path after MBChB. Thank you. Mabiria is hotel clinical versus non-clinical pathways. Interesting. I'll take two more, and then we just launch straight forward into the discussion. I'll take two more. Okay. Okay, let me see if there's any other. Okay, this is the non-clinical options that we have as doctors. Okay. I don't know why everybody thought non-clinical. What if the actual essence of this discussion was clinical space? What if? It's just a what if. So like I said, as I started, so this discussion is divided into two. So the first part will be to look at medicine and business merging. Okay, thanks, Eliud. The first part will be to look at the essence of the discussion. That is, yes, you're there for your 6 years to get an MBChB degree. The question is, I'll want to make it more crude. Then what? Or so what? Initially and in the times past, people used to pride in being doctors, which still to some extent is the case. But then I think things are changing, generations are changing, and time is changing as well. And it is high time as a people, especially who are coming up, the new doctors, we realize that it is not as nice as it used to be. So those are part of the things that I want to bring up in our discussion. And then the last part of this discussion will be to bring in some corporate leaders, like Darius rightly said, and I'll bring it up in my introduction. I'll bring in the managing director and the head of business development in the pharma space. Some of them will tell us what it means to be in a space that is not confined to the wards and the clinics. All right. So that's said and done. I don't know what's currently being projected. Is it the screen where Darius' name is or the slides? Just let me know so that I know where we are.
Personally, I can see MBChB, then what? Then your name, then your qualifications.
All right. Thank you. So when I'm in this mode, I'm not able to see participants and look at chats, but well, I'll be moving back and forth just to be able to engage us. Okay. All right. So my name is Dr. Eliash Dawn. Was in the University of Nairobi. Joined on the 14th of September 2015. That was on a Monday, and left on the 16th, sorry, of July 2022. So we're the class of 20. So it's been about 3 years out here, and tried the other path, which we're going to look at. So MBChB UON and MBA from Liverpool John Moores in the UK. Okay, so that's the brief thing about me. I don't have much, but I wanted to look at this very briefly. So I want it to be very interactive. I'll start with the presentation and then stop me at any point, ask questions, and then we can proceed. Okay. So this is, and I'll be very honest with you because these are the things that I would have wanted an elder brother or sister to tell me when I was a first year, second year in med school. All right. Other than telling me to spend hours, which is good in how do you call it? ADD for the guys in first and second year, cramming the urea and the Krebs cycle, which is good. I wish somebody told me that there was a possibility of spending hours doing that and also doing something else that at the end of the 6 years, I will be more, I'll be more complete and more competitive compared to having finished the MBChB degree and that's it, right? So there are pathways in this field. So this is the common pathway where everybody and anybody would take, okay? So the common route is, and what you guys are now doing is you studying. Of course, there are previous qualifications before this. There's KCP, KCSE if you're doing it the Kenyan pathway. And then there's MBChB, which is the basic undergraduate qualification for all doctors, MBBS in other jurisdictions. And then the common path is after guys are done with MBChB, there are those who immediately go into MEd. So Masters of Medicine could be in anything. Could be in obstetrics and gynecology, internal medicine, pediatrics. That's a path that guys take. So between stage 1 and 2, people spend different times. There are those who spend months, there are those who transition immediately, there are those who transition after years, right? There are those who transition after, of course, immediately after internship. So what I've not indicated here is there's, which I assumed is part of the MBChB program. So immediately after MBChB, there's a 1-year compulsory internship program, which qualifies you to be a doctor, a licensed practitioner within the confines of the Kenyan government, okay? So after that, you have a choice to make, right? During that period, the government does remunerate you, which is good compared to other countries. Of course, there are discussions around cutting that figure, but that's neither here nor there. So after that stage, there is the option. And like I said, you can take different times to get into MEd. And then after that, you get into practice. So that's the common pathway, right? So MEd is not the end of it. After MEd, there are guys who now subspecialize. They go into fellowship, different fellowship programs. For example, somebody studied IMED, can go into cardiology, can go into nephrology, and then they get into practice. So the ultimate goal for a clinical pathway is you get your degree, become a general doctor, get your internal, of course, postgraduate qualification, get into subspecialty training, and then get into practice. You be a very renowned doctor, right? That is the common pathway, and that is the traditional path. So there are those who get to this point on a malizia hapo, they get to MEd, they finish their postgraduate and they stop at that. So they become just general consultants. And there are those who get into subspecialty training and then into practice. So that's a common pathway that we're all aware of. The other alternative pathway, which I'll also highlight, is all of us get the undergraduate training, which is good, right? There are those who, with that undergraduate training, they decide to get into practice, okay? And this is most, because not everybody has what it takes. They don't have either scholarship to go into MEd, or they've not gathered enough financial muscle to get into MEd. So they'll do their internship, and then they'll get into practice as general AMOs, general practitioners, okay? So the time they take here is now up to them. They can take forever, they can take years. If they're employed by the counties, they can spend 6-5 years, and the counties may release them to school. So that is totally dependent on individuals, but most guys actually are here, all right? After that, there are those who, after spending years in practice or months in practice, they will proceed to MEd, and then they continue to practice. Now, let me highlight something on this alternative clinical pathway. It is very dependent, okay? And this is what I'll want to speak to a younger brother or sister who's listening this evening, is these decisions are not people dependent. They are not class dependent. You'll finish as, let's say, this graduating class of 2025, and then there are those who will get straight into MEd. Okay, the decisions to do that are totally financial responsibilities back at home. People, they're paying for fee, and so all they're doing is to study. Okay, so for that kind of cohort, if their path or if the orientation is clinical, they will do well to just finish the MBChB and get straight into MEd, because then the essence of practice here offers them very little. Okay, guys don't practice here to gather skills through routes I'll highlight. You can get the Aga Khan route, the residency route, where you're paid a stipend. You part of it addresses your fee, and then you get a stipend of about 100K a month, and then you spend that as you study, and then after 4 years, let's say you finish your MBChB at age 28, all right? By age 31, you'll already be a consultant, which is good, admirable, okay? There are those who will need to gather that financial muscle at this point to be able to pay for their MEd, okay? Now, let me address two cohorts here. There's a group that, yes, they don't have financial responsibilities, but they want to venture into the space of practice to just, see what happens as they figure out, what life has to offer. For that group, they also pose a bit in practice, but they don't spend too much time here. The risk of spending too much time between these 2 points is, and from my experience, nurses no longer respect doctors, okay? Nurses know who consultants are, they know who MOs are, right? So to get to a point in your practice where you're making orders and nobody is honoring those orders by a doctor, because they know it's not very good out here in terms of that respect. So if you would want to get to a space where you command respect, not just for your patient care, but also for personal, kind of self-actualization, then you'll do well to finish MBChB and go straight, finish your internship and spend less than 6 months to a year. So if you're to practice, let it be not more than a year, and then transition to whichever MEd program, okay? So that's an alternative clinical pathway, okay? There are guys who will spend years here. Either they get employed by the counties, so the counties will give them, kind of will bond them. So they'll have to, for some years, sometimes 3 to 5 years, serve the county before the counties release them on paid study leaves, and then they'll get back to serve the counties. So those guys also spend some time here. And then there's a group that just does not know what they want, okay? They don't know whether to move straight to MEd. They don't know whether to stay here to practice. They just don't know what's going on. And that group will address it, okay? Now, there's this other group that the kind of heat that they have experienced in med school, just like myself, they say, I'm not coming back to school. They are well convicted that not again, not your end, not anymore. Right? For them, I think it's just a matter of time before you realize that you have to go back to school. Okay? It is not all glorious at this point as an MBChB holder. It is not all glorious at that point. You need to advance that schooling. Okay. All right. And then there's the team, wale watu wa MPH. Okay. So this is an non-clinical space, which most of you are hinting was a topic of discussion. So this non-clinical space is also not very clear. Okay. So you do MBChB and then you can go into an MSc. MSc here includes public health, it includes health systems management and all that. Or you go into Master of Arts, okay? Like the path I've taken, business administration and all that. So where that lands you is different, okay? It can either land you into any of this, and I included this deliberately, other corporates. This is way broad, very broad, okay? One thing that we are not told as a traditionally trained doctor is you're not told that there's anything else you can do other than clerk a patient, get a diagnosis, formulate plan of management, and then that is the traditional way of looking at things. And yes, it is rewarding, but from years of having been in that space, it is a space that is rewarding, but at old age. And I'll tell you why. I work in a space where I see consultants, young. Don't look at the guys we see in KNH who have self-actualized and think that is how every consultant out here is. No, all right. The truth about practice as it is right now is that there are guys, consultants who are being churned out of our public universities and private institutions who, after getting their MMed in whatever specialty, struggle out here. And I was speaking with Dr. Museve, who's one of the author lecturers in UON. And he told me that the number of unemployed consultants is alarming. It's alarming, all right? And that was not very strange because just before I finished school, there was a guy, he'd finished ortho. I was in my final year, he'd finished ortho, and there were this, if you've been to KNH parking space, there were these cars that are being auctioned, okay? So the guy had sold his car to fund his residency program, his postgraduate program. And so he finishes ortho, that was around 2022, as a consultant orthopedic surgeon. And he, for 1 year, had nothing to do, nothing to do. So he was auctioning his other car so that he can get how to pay his rent, just a way of paying his rent. And for me, that was ridiculous. Now, let me say something as we proceed from the very onset, that the aim of school, as much as we say it's passion, and we say that our aim is to alleviate suffering, to bring joy to the faces of our patients, that's good. But when that is not rewarded, when that effort is not properly remunerated, then the work that we do becomes a pain or a thorn in the flesh, okay? And case in point is I have colleagues who for a long time, the class we graduated with 2022, who finished the internship. Of course, the government was paying them well, 140 Gs a month. And then after that, that comes to a stop. And then somebody offers you 50,000 shillings a month for 12-hour shifts that run from Sunday through Saturday, okay? The guys out of desperation who went for that, okay? And they're way better, they're better off than guys who, till now, they run from, for locums from place to place, but then for 3 months, the facilities that they are working for or working in have not paid them. And I was speaking with a colleague, I think 2 days back, and she was telling me how she, out of desperation, had gone to one of the big private facilities in Nairobi and had worked, and it's the norm of that facility to bring in medical doctors. You work for 3 months, and then they tell you for the first month they don't pay, and they tell you, we are processing your payroll issues, the payroll issues are being handled. The second month they give you another excuse. The third month, out of frustration because you have to settle your bills, you're not in your father's house anymore. For a majority of the people, there are those who have been brought up in the city, or they have places they call home within Nairobi and its environs. For them, they don't have an issue. But I'm talking to somebody who, you have to foot your bills, you have to foot your transport in all its settings, you have to just earn a decent living, right? So 3 months, you're not paid. And then what they do is, out of that frustration, you run out of that facility. They bring in another AMO urgently. And that is how they've been surviving. So they don't pay at all. And there are several facilities within Nairobi, private facilities that don't pay. And these are things that you just appreciate after you finish school. So it's good to know them early so that as you position yourself, as you build a brand, which I'll talk about as we move forward, you understand that passion is good, but passion without remuneration is a thorn in the flesh. Okay. All right. So that said, uh, let me re-highlight this non-clinical pathway. So these are guys who either out of choice or out of frustration decide that guys, I'm not going to be somebody's one employee. So they get into entrepreneurship. They start their own ventures, either startups or they partner with people, and guys are doing well. So this entrepreneurial route is very broad. It could be from AI, from tech, from tech to uh to supplies to just the kawaida businesses that we look at. And classic point examples are their colleagues who have ventured into the tech space. One of them, I won't mention names, is a guy who finished in 2014, and then went and started a health startup, tech health startup, and then he completely left the clinical space. And he was telling me a few days ago that it gets reminders from KMPDC to renew his license, and those are the he enjoys assuming those mails. He enjoys assuming those mails because he's never going to renew that practice license again, not at all. Mhm. Having experienced the joy that being his own boss brings him, and that of being told to run for labs and samples, he says no. Okay. All right. So that is one space. And this is not a direct path that you have to do either of these to fall into the third bar. No. It can be as straight as from MBChB straight into this third line. And this third line is not very comprehensive. It is so broad. Okay. So there are those who will venture into research. Now, research is broad, very broad, very broad, very broad, and that cannot be overemphasized, cannot be exhausted. But it's also a non-clinical space. There are guys who are doing so well because research gives you the opportunity to just not only say what Hutchison's said, but also think of what you'll have done, right? So that is the power of research, of developing new knowledge, creating new knowledge. And as we move more towards the era of evidence-based practice, which a majority of institutions are not doing, research is a stronghold. Though with the funding the funding cut, it may be a challenge, but then it's a space that one who is interested in creating new knowledge, in improving current practice, can actually venture into. The third space, which of course where I am and which I'll speak more about, is pharma. And then I'll just highlight these others so that we get to know them. There's insurance, and then there are other corporates. Okay. So insurance is so broad, very broad. And here it could be as limited as medical insurance, or it could be as broad as just insurance in general. Okay. And there are doctors who have risen to the ranks of being chief operating officers in these insurance firms who run the show. There are CEOs and COOs, there are managers who are in that space. It does not, let me say, it's not large enough to accommodate many doctors. But yes, it's good to know that as a doctor, there's a space for you in the insurance space. Because, for example, if I see a patient today who comes in and let me give you I know this is being recorded, but I won't mention names. Okay. So there's a facility in this country, a very renowned private facility that harbors most of our professors from the University of Nairobi. Most of them work there. Okay. So these guys had done a procedure, and that was just barhole. If you've ever experienced or been in the theater and seen how bar holes are done, there are 3 holes that are put in your skull to alleviate that pressure and to evacuate whatever contents are in there. So what happens is that, they look at this patient. This patient has a very corporate, very comprehensive insurance, medical insurance cover. And so what they do is for each hole, because bar hole is a single procedure. Okay. So what this and God forbid, one of the lecturers of the university, what he does in terms of his claim, he charges each hole as a separate procedure, right? So for the first hole, he charges 1.5 million. The second hole, he charges another 1.5 million. The third hole, he charges 1.5 million. So the total claim for the procedure, which should have been 1.5 million, is 4.5 million shillings. And it's not the first time this was happening. So it had to take the intervention of a medical doctor who appreciated that and knew what a barhole actually is to convince the insurance that guys, hapa we're being played here. Okay. This 4.5 million shillings is actually thrice the amount that should have been paid for this procedure, because this is a single procedure. Not each hole is separate. All right. So after that, many insurances started engaging doctors in terms of looking at claims and cases. So there's space for doctors. A majority of the people who look at those and review those claims are, of course, CEOs and nurses. But at the top level, where decisions are made, they actually engage doctors to do that. So that's a space you could actually look at. And then there are the corporates. There are banks that hire doctors. We have doctors at Safaricom. We have doctors in government. And here I'll mention briefly the ministries that we have in the country. So in terms of being a civil servant, as a doctor, you're not limited to working under MOH as, let's say, a practitioner, okay? You can be engaged as an expert in the Ministry of Defense, an expert. And the expertise here is not really a pediatrician. No, of course, things are changing, and most employers will want to engage doctors who have some disease specialty, which, of course, gets back to our first slide. You need to get a disease specialty before thinking of getting into these other spaces. So in the government, there's the option of one, you could get into the Ministry of Health as a doctor, okay? So you are employed by one of its parastatals, either the Kenyatta National Hospital, or KU Teaching and Referral, that as a practitioner, okay? Or you could get into the Ministry of Health as, as a health expert, health systems expert, as a policy expert. You could get there as a risk expert. So all these things are not taught in MEd, okay? So there are things that you get at advanced levels of study, either as a Master of Science in Public Health, Health Systems Management. So that space is also there. But then gone are the days when people will, jump into MPH and say that you just need MBChB, MPH, and then get into MOH. Right now, MPH is with everybody, okay? So what makes people stand out is what, in addition to your MPH, what else do you have, okay? So you have an MBChB, an MEd plus MPH. Of course, you are where, you're way stationed higher than somebody who just has MBChB and all they have is a Master of Science in Public Health, all right? That is if you're considering being in the space of government. And of course, those government positions are politically influenced. They're not so given, but it's something that you need to know that actually does exist. And it's a space that you can think about. All right, so let me pause here a bit and look at. Let me pause here a bit and look at if there are any questions up to the point we are at, so that I don't address these things at the end. All right. So is there a question up to where we are, so that I get into the second part of this discussion? You could type it, you could just unmute. I don't know if that the system allows. Unmute and ask. Yeah, let me take maybe one or two and then we get to the second bit. Question in the chat box. I want to go to the second bit of this and just speak to what exactly is happening right now, and why, from my opinion, I will say this is the direction that the practice is taking, and this is where we are. Just so you know, and make an informed decision to do or not to do whatever thing you're planning to do. Okay. Okay. So any question, feel free, so that we can see that you're saying, just feel free to unmute and ask. Yeah. So like I said, for those joined later, at the end of this discussion, I'll bring in my MD, the managing director, and there are questions I want to throw his direction, so that you understand that the people who actually make the decisions out here are not the guys in the ward, right? Let me give you a case. Which example is coming to mind? You're seeing a patient who needs, there's a time I was handling, I was handling acetylcysteine poisoning, okay? And I didn't have any antidote, okay? So this 17-year-old is brought to the emergency department, and you need an antidote, okay? Sorry, I was handling acetaminophen poisoning. Sorry, and I needed either acetylcysteine or activated charcoal, which I didn't have. Okay. So what do you do? Let me ask that. Right. I've seen Kira's question. I'll come to that. I want somebody to just let me engage you a bit. What do you do in the setting where you have the skills, you're trained well, you have graduated from the University of Nairobi, you get a patient who needs your help and you have the skills to help them, but you don't have the resources to help them? What do you do? And limit your answer to that context, all right? What do you do? 17-year-old with acetaminophen poisoning, you need antidotes, you have nothing. Outsource antidote, okay. Outsource as who? You know, the procurement process in most of these private facilities is not as straightforward as you think about it, okay? Yes, you may need to outsource, like what I did in that immediate setting. I had some activated charcoal in my house, so I sent for it. And that is what we at least used uh, for the initial setting, and plus the gastric lavage that we were able to do. But assuming the serum levels of acetaminophen kept rising and I needed an antidote other than my activated charcoal, of course, my hands were tied, okay? Onyango is saying you improvise. Yes, at that point, you may need to think without the box and just try save a life. But it's not always as straightforward as we think. It gets messy. There are patients who will die, not because you didn't know what to do, but because you didn't have what it takes to actually help them. Okay. All right. So that said, I'm not saying that to be in that space is bad. It helps you realize one thing, that there are guys who pull the shots. And these guys know nothing about medicine. Nothing at all. They don't know what that acetylcysteine is. They don't know what that activated charcoal is. They don't know that in a place where you're having mothers giving birth, you need a newborn unit with at least a newborn mechanical ventilation system. They do not understand that. Okay. So there are those who are comfortable with just being in the space of providing care and bringing relief. But then there are those who are interested in much more, in actually making things work. Now, for those who want to make things work, your space. Let me give you an example. Unaweza kuwa KNH as a consultant, you're in 8C8B as a professor, but you have no influence on what medicines are stocked in KNH pharmacy. Not at all. All right? Not at all. Last year, just so you know, because some of these things happen and we're not aware. Last year, there are consultants who are hired in Kenyatta National Hospital without the knowledge of the head of the orthopedics department. These orthopedic surgeons are being hired. Now, as a head of department, as because of course you're a doctor, there are things you'll want to see in the doctors you're hiring. But then somebody who sits at the top of the management decides that, I'm bringing in these guys. I'm not saying they're not qualified, but is bringing in a team that may not have the same vision that you have as the head of the department. So what that simply means is that as doctors, we must come to a point of appreciating that healthcare is ailing because the people who pull the shots have no idea about what healthcare actually is. They have no idea, completely no idea. Either they're politicians or political sycophants, they just have no idea. And so it takes the expert opinion and decisions and actions of a few doctors who are willing to go into these spaces and change policy. Now, with policy, you can affect and impact 1,000 patients at a go or more. While seated in the confines of a clinical wall, you may see one or two, okay? Of course, the impact will still be great, but then you need to understand that it can just be as limited as it is, okay? So that said, I think I'll want to transition to the second space of pharma. And just to let you know what there's a question there. So to get into corporate NGOs, okay, it's reasonable to do public health or health information systems. Yes, Joy, it is more than reasonable to actually do that. Because what makes you stand out? Right now, all of you will have MBChB. And then just to the title we had, so what? Then what? Okay. Then what? Then what? Okay. So it takes that extra effort to get something that is unique. And it doesn't have to be MPH because everybody's going into that space. You have to think about, there's some masters of science. Like right now, the universities offering programs of masters of science in AI, in healthcare, health information systems, and AI. The current trends in practice that you need to be well aligned with, so that as you get into that space, you already have your MBChB degree, and then you have something on top that makes you different. Okay. So it's advisable to have this. And just like I mentioned initially, this is not enough. Once you get your public health systems, it will be more advantageous if you had both your MMed, MBChB, MMed, and this one. Okay. But it doesn't pain to start with the MPH or the health systems, because they are organizations in Kenya right now. They're looking for doctors who have MBChB and either an MPH or an MBA. That's all they're looking for. That's completely non-clinical. All right. So that's a path you could take as well. Mike is asking on the topic of unemployed consultants, what could you say is a course need for further subspecialization? So thanks, Mike, for that question. Actually, you have brought to mind what I almost forgot that I need to address, okay? 5-10 years ago, doctors were being employed and there was no issue, okay? So you'll finish your undergraduate MBChB degree and then get into the employment space, right? You'll be posted by the government. So you'll not, for any given point, unless you decide, be unemployed. So that changed when the government stopped that direct absorption of doctors. And so what happens is the private facilities that we have, because I think 80 to 90% of doctors are currently employed under that private space. So when the government stopped employing, sorry, this private facilities actually started playing games. Because if the government cannot employ you, then you don't have an option. So we reduce the rates at which we are engaging doctors, okay? So they reduced their wages, right? So that happened. Universities continued churning out MBChB graduates. I don't know UON, how many they admitted this year, but there's a time they admitted 500, okay? It does not mean that Kenya already has met the patient to doctor ratio. It has not by far, according to the WHO recommendation, it has not by far. But the government is not in the space to get all these doctors engaged as per the WHO recommendation. So what happens is that guys finish school, guys do the internship, and then there's a backlog of doctors who are not being absorbed by the government, and the private facilities can only take as much, okay? So what happens is that there are so many AMOs. So there's demand, right? But the supply is even greater. So what happens? The law of demand and supply, right? So I have to lower something to just breed that balance. So the MBChB graduates became very many, the AMOs, okay? So that market became flooded. I'm addressing Mike's question. So that space became flooded. So what happens is, as a means to curb that, guys ran to the next level of training. Because if I'm not being employed as an AMO, maybe if I become a consultant, I'll get some space, which is true actually. Those who went to train, they reduced their competition, okay? So if you look at from the year 2022, from the time we graduated, everybody thought that that was the escape route. So you finish so that you don't remain unemployed, you go back to school and do your M.Ed. And so the space of consultants as well has become, not yet, but is becoming increasingly saturated. I'm not saying the patient doctor ratio has been met. No, that has not been met. But in terms of employment opportunities, that space is becoming increasingly saturated. And this in the next 3 years, or even less, the same thing that happened with the space of AMOs will happen at the level of consultants, and it's already happening. I remember when I was working at some facility in Western Kenya, a consultant calls, an orthopedic surgeon, and calls me as the AMO covering the emergency department and tells me that, did you watch the news? Did you see those guys who were shot, trying to cross the border and were beaten and were injured? I tell him, not heard of that, but what's the issue? Those guys are my patients. Kamuuliza doc, okay, so what do I do? Kaniambia, let no other doctor handle those patients. Hao ni wangu. Those are my patients. Because they'd been beaten and they'd suffered multiple injuries. So this author guy calls and says, those cases are his. And no other doctor should handle those cases. And it's not just one isolated case, several cases of doctors fighting for patients. And if you look at the practice around here, especially in the private facilities, it's bad. You look at guys who spend 5 years. I'm not saying it's not bad, not good to spend those years in school. You look at them and you look at the kind of frustration that they go through, either to be employed by these private facilities. I know facilities that pay consultants 12,000 a day to see patients. 12,000 a day as locum fee for a consultant is just, it's just somebody telling you, guys, you need to do something better. They need to find some other space. That is what they're saying in essence, okay? So that space as well has become saturated, and it's increasingly becoming saturated as more doctors transition into the M.Ed programs, okay? But then there's the advantage with that is then it makes you unique. You're not just a general doctor, okay? You are a physician, and with that, you can still go the non-clinical space. So you don't have to go the non-clinical route at the MBChB level. You can get to that level of a consultant and still go the non-clinical space. And now to just go to pharma, if you look at what pharma does, and I'll be bringing in our MD to speak briefly about pharma. If you look at what pharma does, and part of what I do as a medical advisor is for therapeutic developments and these therapy areas, let's say, for example, endocrinology or cardiology, we engage specialists to advise, that is as part of advisory boards on what are the prescription trends, what are the new developments in the space, in that therapeutic space. So we engage doctors. For CMEs and webinars, we still engage consultants and specialists. So you could be a specialist in any field and still go non-clinical. Of course, the question is you'll have spent some 5-6 years in training, but maybe which will not be utterly lost. So I think that is what was being asked, and I hope I addressed it. Okay. All right. I can see the MD is already here. And I'll bring him in a few after I address this part. Okay. So I think that is already clear. So pharma. I brought in this slide particularly to address one thing. And as doctors, what we miss in our training is one. Nobody tells us that after this training, you'll need to earn a living. Okay. It's so traditional that you finish your degree, you'll see patients and the government will do something. It stops at that. But nobody says that, you need to be more than a doctor. All right. And there are endless opportunities that whatever training you have can grant you in whatever space you want to venture in based on your interests and your drives. Okay. So if you look at the dictionary's definition of what a career is, and I'll highlight the two points that are made in bold. Any career, it spends you. A majority of your life is spent in the training, just to acquire the knowledge. But then the most important thing for any career is that it needs to have opportunities for progress. So if this is lacking, then that's a sham. If in a space where there is no, and sometimes I used to look at part of what pushed me non-clinical is I used to look at, and I'll give you a classic example. If you go to 8C in KNH, there are things that could not happen in 8C until Professor Binya retired. All right? There are things that just couldn't, Dr. Hiro, Dr. Andrew, there are things that they could not do, not because they're not fully trained, but because there is somebody who was as a godfather, whose presence alone, meant that nothing else could happen until he exited in form of retirement. That really is not exciting. Waiting until somebody retires so that you become an associate professor until it's not really rewarding. But that is the clinical space. It takes time, it requires patience, and its yield is at old age. So if you're a guy who's patient enough to allow that to happen, then the clinical space is something that is for you. And we've highlighted the path, okay? But I think it's important that we remember that opportunity for progress is very important in whatever space you are in, okay? So there are these two last parts that we look at. So MBChB in pharma. Now guys are asking me, what are you doing? And the question here is, what does a doctor do in the pharmaceutical space? What does a doctor do in the pharmaceutical space? So I want to bring in our managing director, Universal Corporation Limited. And just to give you a brief so that you understand about Universal Corporation Limited, it's a pharmaceutical manufacturing company in Kenya, a local manufacturing company based in Kenya that does manufacture drugs. And the other thing that makes it stand out is that of all the pharmaceutical companies in Kenya, it's the only company that is pre-qualified by the World Health Organization to do supplies and do manufacture, especially drugs that go to USAID and UNICEF. So it means it's been given some special status, having met some given qualifications. So of all the drugs you'll see floating and flying around your corners, it's only Universal that is recognized by the WHO. So if there's a tender business to supply the anti-malarials or antiretroviral drugs within Kenya, Africa, and beyond, they'll look no further. They'll just get to Universal Corporation Limited. So it's our pride as Kenyans to have a local manufacturing company with the state of art that it actually does have, and to understand. And if you look at this second slide, which also the MD will talk to, is what most doctors don't know about drugs. So I'll handle these last two, and then we'll get back to the nexus between the career path of a doctor in either the pharma space or other corporates, and then we'll take a few questions and then just call it. So I'll bring in our MD to just address, is there space for a doctor, and what does pharma actually look like? Because my 6 months are not enough compared to your 40 plus years of experience in the pharma space. What is pharma, and what really is the space or the position or the place of a doctor in that industry? Mr. Palu, if you can hear me, over to you.
Yes. Hi, everybody. Thanks, Doc. I think it's not a very difficult question. Doctors have a lot to do in common with pharma. You are our go-between between the patient and us. And as a doctor, what I'm sure many of you or most of you will not know how a product is manufactured. Maybe in theory, yes, but in practice, it's a very tedious process. I think maybe, Doc, you can expound on it once you're there. I'll not expound on that. And quality is the key. As far as Universal is concerned, we believe the patient is first. We have learned that we should not compromise anything to do with quality where the patient is first. And that has a lot of processes. I think what we can do is we can invite a few of you in batches to come and visit Universal. Maybe, I don't know the timings and all that. I think Dr. Eliash will be able to give you at a later date, but that's clear that you learn more about pharma. And when I say a product is quality and non-quality, the difference in price is not that much. If we all believe that, and I think we see a multinational price and we say pharma is expensive, but it's not expensive. If we see the generics, which are branded generics, they are much cheaper than the brand or innovator product. So what we manufacture, we make sure that all the tests that we do are comparable to the innovator, and that all the release parameters for the body to absorb are met within the confines of the pharmacopoeias. I know I don't have much time. I think I saw a very good question. What are the next steps? I mean, what is the career path? And I'll give you a good example. I have a very good friend of mine who is an aeronautical engineer, but is running a hardware shop and very successful. So it doesn't mean that you must be in pharma or doctorate only. All I know is once you get a degree, your mind opens up. And then it's on a personal, individual level on how eager or how you have a self-drive. Because at the end of the day, I think all of us have to make something, whether it's a company or it's an individual. But what you make has to be reasonable, not the fleecing type. So I don't know if I've answered that question. And really, pharma has a very good connection with the doctor. Because as I first mentioned, it was the doctor who is our go-between to get the patient take the medication. But how, as a doctor, are you sure that the product you're prescribing is manufactured with the highest quality and a most affordable price. And if you noticed, I didn't say the word cheap, I said affordable price. So I don't know, I may need to stop here. If somebody has some questions, I could answer that. The next slide was on, Doc.
Let me pull it up. You had
So
started
there is
addressing
pharma.
it, yeah.
Yeah, so pharma and practice, I've said where they meet. The meet is the patient. So if the patient requires product X, on what basis would you prescribe a paracetamol from company A or company B? Or would you prescribe a generic? I think this is where quality comes into play and where many doctors would not be aware of. Maybe the package looks excellent, but is it really excellent quality inside the package? So let me stop here if there are any questions or if you have some other clarity we need to make. And as I said, if a doctor, I mean, if you go into marketing as a doctor will understand the doctor much faster than a biochemist who we have as marketing reps today to go and meet a doctor. Because as it is, the biochemist or the chemistry-based person feels inferior to the doctor anyway. And some of you as doctors really have, I would not say stupid questions, but very sensible, but very automatic questions. But then the rep is so confused how to answer it. They feel inferior to the doctor. So even that is a huge opportunity out there for choosing marketing or sales as a doctor as well. If I stop here, if I have any questions.
Okay, all right. Thanks. If there be any questions, I think the MD is still in to address them. So just be putting your questions in the chat space. We'll address most of them. So I think that gives us a picture of what pharma really is. And just to tell you that some of us who finished MBChB had no idea what pharma really meant until we went into that space. So like the MD has rightly mentioned, there's space and there's room in the space of marketing and sales. There's room in terms of research, because if you look at these new molecules that are being brought into play, they don't just get out of nowhere. It takes the minds of doctors and specialists and scientists to, let me give an example of the newest GLT2 inhibitors, okay? That would not have happened if their doctors would not inform that that was what practice needed at that point. So there's room for research in pharma. There's room for product development. There's room for business development. There's room for marketing. There's room for just so much, all right? So with that basic, I will call it basic undergraduate training, your mind is open to do excellent excellently well in many aspects of practice. And so the aim really of this discussion was to let you know that, you're not confined as a doctor to the four walls of a clinic. You're not confined as a doctor to the four walls of a ward. You're not confined, right? That is good, and that still will complement what you do, but there's space and there's room. And as things are changing, the government and the private space are not absorbing doctors as they used to. It calls for each of us to start thinking differently, because at the end of the day, then you need to have food on your table, right? So it doesn't have to be in the spaces that have already been outlined. It can be as broad as you thinking and just going back to your village and starting an agribusiness. Okay. So agriculture is also a space for doctors as well. Gone are the days when a doctor must see patients, okay? But with that basic undergraduate training, then you have what it takes. And what I thank God for having done the MBChB is that even if it took 7 or 8 years, it gives you room to do basically anything. All right. You can go into law, you can go into business, and like a lawyer cannot just transition from law into medicine. They'll have to get the training first. Okay. So there's a medical legal aspect, which also is a space that one can venture into. So let me see if there are questions that we want addressed. Either you unmute to just put it in the chat box so that we don't spend too much time here. And like the MD has said, I saw that we're planning to have cohorts just come to Universal to have a feel of what pharma is and a feel of what, quality. Maybe as the questions keep coming, maybe Mr. Palu, you can speak about cross-contamination briefly, and then we address these questions here, and then we just call it a day.
Sure. So we had several questions that were asked. We asked questions to doctors about patients, and including Dr. Eliash. We said that if I come with a headache, so majority of you will prescribe a paracetamol. But when I have that paracetamol, the next day I have formed blisters. I come back to the doctor and say, my dear, yesterday you gave me this medicine and it's given me these blisters. Now, there is no side effect documented for paracetamol to have blisters and boils. Am I correct in that, Doc?
Yes, you are. Yeah.
So, what exactly do you think as a doctor could be, what is the next course of action you would take? Anybody can answer that?
Let's throw it to the students. Guys in their clinical years, all right? A patient comes, they're on paracetamol, they've come with blisters on the skin. What are your next steps? You can unmute and speak, or you can just type in the chat space. Mamra is saying, stop the drug, stop the drug. Joy is saying, stop the drug. Anyone else? Most of them are saying you stop the drug.
Yes, but the other action you would also take after stopping the drug is send the patient for a lab test to understand what the boils could be. Would that be the right course of action?
Zotel is addressing it to an extent. He's saying withdraw the drug and investigate the cause. So as part of the investigation is you do a lab test to check if there are any levels of whatever drug that you gave that are toxic to the patient. So yeah.
Okay, so in actual sense, what would have happened? I'm just giving, I don't know the product, I don't know the manufacturer, but wherever this product you gave and prescribed, when the patient took it, is from a company that manufactures several drugs together at the same time. We as generic manufacturers manufacture several drugs together at the same time in several different rooms. And the areas are controlled through pressure differentials through the ventilation system. So product A does not lodge on product B by mistake. So when the product A has lodged on product B, now let's say in product A, I mean a penicillin, and product B, I mean paracetamol. So the penicillin has lodged onto the paracetamol. So when you send it to the lab for a test before you release the product will pass the laboratory test because you're testing a known standard of paracetamol against your sample of paracetamol. So obviously it will pass. But the penicillin has some milligrams or micrograms of it has lodged onto the paracetamol. Now, I, as a patient, am allergic to penicillins. Obviously, the boils will appear. Now, what has happened by prescribing a substandard product is you've increased the patient burden, you've increased your lab burden. Instead of prescribing the correct paracetamol or the proper known product for quality, as opposed, and the difference in the price of that would not even cost the patient 100 shillings. And even 100 is too much in a paracetamol. I think even 20 bob would not be there. And the person now has already gone through a lab test, another drug, you give him a higher antibiotic. So all in all, the patient ends up spending more than 5,000 shillings, whereas the right paracetamol would have costed him 25 or 50 bob or 100 bob more, as an example. So I don't know if I've answered. That's known as cross-contamination in a facility which does not have the right control systems during manufacture. I'm sure
Yeah,
as a
yeah, sure.
doctor, if you would understood that, I'm not sure. But if you are taught that, I'm not sure.
No, nobody actually teaches that. And most doctors sitting behind consultation desks will just prescribe what is in the pharmacy. But rarely do we think of where does this product come from. So a lot of patients we see with drug reactions, some are actually not because of the drugs that they took, but because of a cross contaminant. And that's why it's important as a doctor from the early training years to appreciate quality, so that as you spend time investigating and clerking and working up a patient, you don't do that just to end up giving something that will push them to the end of drug reactions, and you know how bad it can be, from TEN to Steven Johnson's and all that. All right. So that kind of sequelae can be avoided by having a doctor who understands that there are players in this space of patient care that are not doctors. Okay. Others are in the manufacturing space, and all of us have a role in ensuring patient safety and that the patients are well taken care of. So there are questions that are coming here. I'll want to ask the MD to address the ones that he can address, so that even if it drops, we can now handle the rest. There's one who's asking, Grasha is asking, I'm not sure if my question was answered. I lost my network for a while. Does Universal offer graduate programs?
Okay, so
Does
we don't
Universal
offer graduate programs, but what we do, we have something known as a trainee program. In the trainee program, we get fresh graduates who are willing to come into pharma. Well, whether it is marketing, sales, plumbing, engineering, HR, IT, finance, business development, QA, QC, all across the board. And we bring the people as a trainee. We do not bond the trainee, neither do we pay very high salaries at that time. But hoping to onboard them if they are going to be an asset for the company. And if they find a better job in between and they want to leave, we do not bond the trainee. So unfortunately, we don't offer any graduate program, but we do employ graduates who can come and join, obviously, if there is space in that department. But yes, the answer is as a trainee, yes, but not as a graduate program.
All right, thanks. Adnan is asking, how can we get to visit? Adnan, we in the process of having these discussions, and when the discussion is final, like of course through the association, we'll communicate so that we have groups come in batches to appreciate what happens in pharma, to just see what goes on into that one tablet of paracetamol that you prescribe. All right, that will help you think differently about practice and prescription. Okay. That is Adnan. Okay. Let me see. Kwayu is asking, and to see if there's any question that, if you have a question that you would want to address to the MD before he leaves, drop it here. The rest, like for Kwayu, I think those ones I can handle. So if there's any question, verbal or written, I'll give you about a minute to just put it in the chat space. And then if there be any that would want him as an industry expert, that is what we don't appreciate, as ours is confined to the clinics, but even in healthcare, the industry expert. So as an industry expert, it doesn't have to be limited to pharma. If you have a question in that line, you can throw it here, and then I'll give him some time to respond, and then the rest, we can spend about 5 minutes to close. If there are questions, just keep them. Queries asking how you got into pharma. Is it true that a doctor needs practice for 2 years after MBChB before you do an MBA? Okay, I'll handle that. Are there funding opportunities for MBAs? Okay. All All right, that I'll handle. I'm not seeing any that is directed to the MD. Maybe he has addressed most of our concerns, and moving forward as we develop on these talks and this engagements, I think we'll get to understand more and more. So thanks, Mr. Palu, for your time.
No, thank you very much, guys, and all the best. And I think career-wise, if I were you guys, you have a very open mind. And one thing I learned about doctors, you first listen and then you give your judgment, whatever it is. Now, that quality is a very rare quality to find in many other professions. And with that quality, please do not be scared that you must be in pharma or medicine only. The whole world at large is open, and it's how aggressive you are is where you can take your career. And that's my only parting shot, I would say here.
All right. Thank you so much.
All right.
Thank
Thanks,
you so
guys.
much. All right.
Thanks. Bye-bye.
Bye. All right. So that was the managing director for Universal Corporation Limited. And I think he's addressed most of what you'll have wanted to hear in terms of industry. So Kweyu Joy is asking how if you have to spend 2 years after MBChB to actually do an MBA, the answer is no. You don't have to spend 2 years after the undergraduate degree. I'll share a link. Let me just put it up here. Or I don't know if I share it in our mails. There's a link that I shared with just a minute. A friend of mine wanted to, the link here. So there are scholarships for MBAs and other Masters of Science that you can pursue. And there are very many. There are very many. Mine was an 89% scholarship. So I ended up paying about just 300K Kenyan money, while the whole course is about 3 million shillings. So those who want to explore, I know there are those who have not finished, but of course it requires you to have an undergraduate degree. But that said, you can still explore options that are available. So if you use that link, you'll see all the programs that are there, from Masters of Arts in anything, all right? And once you apply, you can then ask for scholarship, and I can guide you into that. Okay. The other part that Kweyu asked is how you got into pharma. Honestly, really, there's no direct path. Sometimes these pharma spaces keep advertising. Sometimes they ask for doctors in the LinkedIn spaces. Yours is to just put yourself available. And let me say this because I may not remember to speak it. As a doctor, especially once you graduate, the path is very unclear. It is not as clear as I put it in the charts that you finish this and get to this. It is not as clear as that. What works and what I'll tell you as an elder brother is pick what comes your way. Okay? Do it as you figure out what you want to do. All right? And of course, it shouldn't be demeaning, but be willing to do what comes your way first. Some will be ugly, some will be beautiful, but then that gives you the experience that you need to get into the next space. And I'll give you my own story. After my internship, came back to the city. My internship was in Tenwek in Bomet. Came back to the city for about a month and a half. I walked the streets of this city looking for jobs. All right, to the point that I wrote mails to all facilities. You know, the mail application. All right. After that, went to these facilities to ask if I could volunteer, because there was word going around that, for these facilities, if you go volunteer, maybe you'll get into the system. I tried that. That did not work for me. For others, it worked. For me, it did not work. And then a friend calls me that, there are local opportunities in Western Kenya. My friend, Western Kenya. And I've been in Nairobi all my life for a wage of about 7,000 shillings a day. All right. So that I took, okay, because I had nothing else to take. And I felt that my skills were were slowly rusting. So I went to one of the facilities in Western Kenya, specifically Bungoma County, and stayed there for about 6 months, right? Of course, if you look at the wage, it was about the same amount a doctor will earn in Nairobi, and the cost of living was way lower. I didn't know that whatever skills I was getting there were preparing me for the role that I currently play. And just to maybe show you what I do in my day-to-day life, let me just show you that, so that if you're interested in it, you can pursue it. You may be asking as a doctor, what do you do? Just a minute. Okay, let me stop sharing, and then we'll be done in about 5 minutes if there's no other question. Where is my... Just a minute. What I do. So as a doctor, we mentioned it in passing, but as a doctor in the medical space, in the pharma space, so what I do is to form and execute advisory boards for various therapies. So for example, if you are looking at anti-malarials, no, that's not interesting. Anti-cancer meds, okay? So it is my duty as a doctor and as an advisor for the company to bring in consultants who have skills and experience in the space of oncology to form an advisory board for the company, okay? So the only person who can do that is somebody who understands what oncology really is and what a doctor needs to do in that space, all right? The other thing that I do is to, you see, when reps walk in and they have some scientific communications, it's my work as advisor to approve all those communications to ensure that they're in line, they're well referenced, and they're up to date according to the latest guidelines, okay? Part of the other thing that I do is it's not limited to the office. And if somebody wants a blend of something that is, 8 to 5 and a bit of field work, it's a good space where you do field work, where you meet key opinion leaders. Here, of course, are consultants, expert leaders, industry leaders, to just derive insights relevant to the therapies you're in, okay? Part of the things that I also do is to train the reps. The reps, like the MD said, their background is in biochemistry or molecular biology. They have really no or limited knowledge in terms of pharmacology. So that you conduct CMEs and webinars, you moderate and present. You, as a doctor in the pharma, you provide medical rationale. For example, right now we want to launch or venture into the oncology space. As a doctor, I have to give the company what rationale medically there is to launch those new molecules. And then you, of course, assist the marketing team with developing cases for new business cases, for the chronic therapy areas, the antidiabetics, antihypertensives. And then part of what you do as a doctor in pharma is to just lead pharmacovigilance and documentation. So if a drug is reported to have caused some side effect, you recall and investigate, all right? Medical camps, you identify new molecules. For example, right now, prescription in the cardiac space is moving to the SGLT2 inhibitors, the sacubitril, not SGLT2, but the ANI, the angiotensin receptor neutralizing inhibitors. So if you want to go to that space, you have to tell them, because they do not understand the medical rationale. So as a doctor, you have to tell them that this is where practice is moving to. And in the cardiac space, studies have shown that this sacubitril valsartan combinations, of course, have greater benefit for patients who have comorbid illnesses. So that is what you do as a doctor in that space, right? So you have nothing to do with production and granulation, which if you're interested, of course, you can venture therein. But then you have so much to do as a doctor in the space where you provide expert opinion. So for example, from my end, I do not have an MEd, but what I do is actually expert opinion, right? Because all you need for you to do that is to have that undergraduate training. So yes, there is space, great space and opportunity in pharma that we can explore, that all of us can explore. And just like we said as we were starting, the clinical space is increasingly becoming very demanding, very very limited in terms of opportunities. And so it's high time we thought of alternative paths other than the traditional route of MBChB, MEd, practice. And to conclude, I will say that it does not pay. Honestly, it does not pay from where I sit to go back to school for 5 years to come and present your papers to somebody who never went to school. Honestly. But if you're thinking of starting your own practice, go into MEd, and you don't have to study MEd to go into your practice. I have friends and colleagues who've started very thriving institutions. So guys, the bottom line is that the path is not clear. Be open-minded. Try anything that works. Try anything, including content creation. Maybe that will be a new path that you'll create for the people who come after you. So thank you so much for having me. Thank you for spending time to be here. I hope it was a blessing and hope to have more interactions, and God bless.
Thank you so much once again, Dr. Eliash Dawn and Dr. Palu. I don't know whether he's still around or he left, but thank you so much. It has been an amazing session, and today's discussion has been an eye-opener for all of us that an MBChB alone is not enough, and even an MEd is becoming saturated. So as this landscape of medicine keeps shifting, I advise my fellow students, I mean, just as I've been told today, keep thinking beyond the conventional path. And the future belongs to those who are more aggressive, just as Palu said. So thank you so much once again. And your impact today was very, very positive. And we look forward to more sessions and interacting with you in any other way. The other thank is to the Office of the Vice Chair, AMSUN, that is our very able leader, Vivian Mukami. Thank you so much for organizing this and making it very, very possible for us. And we look forward to more sessions. Dr. Eliash Dawn, you shared a link with us today for people to apply for some masters that if they're willing. And I would like you, I don't know whether you're open to sharing your contact details so that those who want to venture into those sites can contact you later with more questions and opportunities.
Let me just put my email address and phone number in the chat section.
Yeah, that's okay. That's okay. Then I'm being reminded that we have another event again from the Office of the Vice Chair. It is on the 26th of March from 2 p.m. It is a talk on USMLE. So guys, join and let's keep planning and become better people in the future. So thank you so much, everyone.
All right, thanks, and have a blessed evening.
You too. So guys, the meeting is adjourned and feel free to leave. Thank you all for joining.